Hi, this is Alice Mims from The Ohio State University in Columbus, Ohio. So I wanted to take the time to discuss the topic of improving outcomes in patients with molecularly defined high-risk AML. So we think of molecularly defined high-risk AML as patients with genetic features considered as adverse risk by the 2022 European LeukemiaNet or ELN risk classification, with some of the most common ones that we come across in clinical practice, including complex karyotypes, KMT2A rearrangements or MLL rearrangements, TP53 mutations, or those now defined as MDS-related gene mutations. So one caveat to this, though, is that the new ELN 2022 criteria considers FLT3 internal tandem duplications or FLT3 ITD mutations as intermediate risk. So many clinicians don't necessarily agree with this due to the high risk of relapse and feel that these patients should still be viewed as high risk. So to improve outcomes in patients with molecularly defined high-risk AML, one of the first items of importance is that all patients really should have cytogenetics and molecular sequencing sent at time of diagnosis. So these results can impact a few different things. So initial upfront treatment decisions, as well as long-term treatment determinations for best chance of cure, such as the role of allogeneic transplantation for patients who are candidates. These results also can be followed serially during treatment as potential ways to assess measurable residual disease or MRD, which may be also important in guiding treatment decisions later on in therapy in particular patient cases. So as our current standards of care do not lead to cures for the majority of patients with AML, it would also be important for consideration of clinical trials, especially those that may include small molecule inhibitors or immunotherapy for a more targeted approach. So I was going to go over some updated trial results that were presented at ASH or new data that's come out this year in the context of TP53 mutated, FLT3 ITD mutated, and KMT2A rearranged AML patients specifically. So for patients, I'm going to start off talking about TP53 mutated AML first. So these patients currently have no standard available therapies that are effective, and overall survival is very poor, with less than 10% of patients living for one year after time of diagnosis. So unfortunately, even with the addition of venetoclax to hypomethylating agents such as azacitidine, this did not really seem to make much of a difference in this patient group in the VALIA study, where patients, if they had venetoclax and azacitidine or azacitidine with placebo, lived for on average 5 months. So really no big difference there, unfortunately. So one approach has been looking at targeting CD47 on AML stem cells as a potentially molecularly agnostic approach. So this leads to simulation of macrophages to kill tumor cells. And so there were updated results of a trial with triplet therapy with venetoclax, azacitidine, and magrolimab, which is a CD47 antibody in newly diagnosed AML patients that was presented by Dr. Dauber and colleagues. So in 27 newly diagnosed TP53 mutated AML patients, the CR/CRI rates were about 63% and a CR rate of 42%. So this is encouraging. And so the agent is moving forward in development and combination therapy with 2 ongoing randomized phase 3 studies, both in newly diagnosed AML patients, one in TP53 mutated patients specifically, and the other for any newly diagnosed AML patient who is not a candidate for intensive induction therapy. A second agent that has shown promise in TP53 mutated AML is APR-246. So this is a prodrug that converts to methylene quinoculianone, or MQ, under physiological conditions. MQ then binds to cysteine residues in mutated TP53 and leads to stabilization and shifts the equilibrium back to the functional conformation of the TP53 protein. It also has a second mechanism that's thought to contribute to early leukemic death, which is increased susceptibility to ferroptosis by depleting glutathione, which increases lipid peroxidases. So recently, in December, Dr. Mishra and colleagues published in JCO a study which used APR-246 as post-transplant maintenance therapy for TP53 mutated AML patients. And it did show improved outcomes compared to historical controls in regards to post-transplant relapse-free survival, overall survival, and did not show an increased incidence of graft versus host disease. So we'll see how this agent continues on in development in AML, and specifically for TP53 mutated AML patients. So now I want to shift gears a little bit to talk about FLT3 mutated AML patients. So for patients who are not considered candidates for intensive induction therapy, venetoclax and azacitidine is currently considered the standard of care in newly diagnosed patients. The LACE-1 study that was published by Dr. Wang and colleagues in Blood of this past year did not unfortunately show improvement in overall survival for FLT3 mutated AML patients when adding gilteritinib to azacitidine compared to azacitidine alone. However, Dr. Short presented updated results of a triplet trial with therapy with venetoclax, azacitidine, and gilteritinib, and showed in 27 patients with newly diagnosed FLT3 mutated AML, there was an overall response rate of 100% and a CR rate of 92%, with a median 1-year relapse-free survival of 74% and 1-year overall survival of 85%. So though these are small numbers for the patients in the study, this is very encouraging initial data. And so hopefully we'll see more as this combination therapy moves forward in further studies. And so finally, I want to end with talking about KMT2A rearranged patients. So our MLL rearrangements. So menin inhibitors are an exciting population of drugs that are showing single agent responses in relapsed and refractory AML and ALL patients. So KMT2A rearrangements result in the creation of an oncogenic fusion protein, including the N-terminus of KMT2A with more than 50 possible other fusion partners conferring hyperactivity and or aberrant genome targeting. So the interaction of the KMT2A fusion partner protein with menin is a key driver of these acute leukemias. The binding to menin localizes these fusion proteins to chromatin, which enables a leukemic transcription program. And this leads to upregulation of Hox genes, which activates aberrant gene expression along with their cofactor MEIS1 and leads to leukemia through differentiation blockade. Menin inhibitors bind menin to displace these fusion complexes and turn off the leukemic transcriptional program found to be important in both KMT2 rearranged AML and ALL and NPM1 mutated AML genomic subtypes. So at ASH, Dr. Issa discussed updated results for the menin inhibitor SNDX5613, which is an oral twice daily agent. So this was a phase 1 study initially in relapsed refractory AML and ALL and was amended to just include NPM1 mutated or KMT2 rearranged relapsed refractory patients. So the responses seen in the efficacy population of 60 patients with either NPM1 mutations or KMT2A rearrangement showed an overall response rate of 53% with a CR/CRh rate of 30%. And then looking specifically at the KMT2A rearranged patients, there were 46 where there was a CR/CRh rate of 33% and an overall response rate of 59%. Some noted treatment emergent adverse events were grade 2 differentiation syndrome in about 16% of patients and dose-limiting toxicity of a grade 3 asymptomatic QTc prolongation. So this study has moved forward into the phase 2 portion, which is ongoing. So we're excited to see results from this, and then also is being developed in combination with other agents in the frontline setting. So as you can see, there's a lot of work being done in the high-risk AML patient space, and even beyond what I had time to go over today. So I hope you found this informative, and I thank you so much for your attention.